After the induction therapy has been given, we are now increasingly using a terminology called minimal residual disease, or MRD, either negative or positive. So after completion of these combination cycles of therapy, if a person is MRD negative, many patients these days, they choose to collect their stem cells and keep them in the freezer and not do the transplantation or the melphalan chemotherapy. After the collection, they go straight to maintenance. For patients who are MRD positive or have even more disease in the bone marrow, we would strongly recommend that they do the transplantation. And for full disclosure, there are many centers that still recommend transplantation for patients who are MRD negative. But there are a lot of patients who question that. And I talked to you about before that there are patients that are not candidates for transplantation, and if we check their MRD status after the combination therapy is given, they can either be positive or negative, obviously. So going forward after that, the next question is, could therapy be stopped or should there be a continuation? And maintenance is something that we are using in the United States, usually till progression, or if there is a toxicity. Outside the United States, there are many times restrictions in terms of how long the insurance would pay for the therapy. Some patients choose not to do maintenance. I remember you and I talked about it, and you chose not to do maintenance.
That's correct. I had so much chemotherapy during my stem cell transplant and prior that I wanted to give my body a rest, and I elected not to go into maintenance.
And I remember we talked about this a lot, and I said to you, there is a little bit of a conflicting literature. There was a conflicting literature at the time when we had to make this decision, whether that impacted survival or not. The literature said that the progression-free survival was longer, but really that's terminology that just means that the disease stays away slightly longer. Mm-hmm. But I also told you that if the disease were to come back, we could then retreat it. So if it lasts longer with maintenance, and we have to retreat if it comes back, or if it lasts slightly shorter without maintenance, and we retreat it, it would be the same retreatment, but you said, I don't want to be on any therapy at all. Right. So you therefore opted out.
Right, I did.
So that was the right decision for you. And a lot of people choose to do that.
Yes, for me that was the right decision.
I think if I look in my clinic today, and if I think 10 years back, I think an increasing number of people probably opt to do maintenance. But there are people like you did who choose not to do so. And I think we are just different in our opinions, and if the disease comes back, we can always restart therapy. So in your case, you chose to do no maintenance. So either with or without maintenance, in a way, the follow-up would be the same, because we would still see each other and we would still monitor your blood tests. So without maintenance in your case, we decided to check the labs, and I think we first decided to do about a month interval. And then I gave you the option to do either 1 or 2 months, and then I gave you the option to do 2 or 3 months. That's usually how we follow after completion of the transplantation, or if the combination therapy is given after collection and there is no transplant, we would do about those intervals. And what we really are looking for is actually a series of markers. So one of them is the monoclonal protein, if it's there. 80% of patients with myeloma have an M spike, and you did have an M spike at the disease presentation. And we also would look for light chains, the kappa and the lambda light chains. And we're also tracking a lot of other markers. We are looking at the kidney function, the liver function. We are looking at electrolytes, the calcium. We're looking at the CBC, meaning the red cells, the white cells, and the platelets. And we're looking at other markers of cell proliferation. So every time we saw each other, I ran that same battery every time. Mm-hmm. In my practice, I did not do 24-hour urine each and every time. We would do that at the baseline diagnosis, and we would then track in the blood. I think the literature today suggests that the need for 24-hour urine over time is not really supported by the new literature. So the blood test would be sufficient.